Hi, my dear students. I'm Dr. Jeetu. Today we'll be dealing with acute gingival infections and their management. My reference is Current SAS 13th edition. Moving into presentation. The term acute gingival infection includes three entities. One is acute necrotizing ulcerative gingivitis, two is acute herpetic gingival stomatitis, and three is pericoronitis. All these three are acute infections of the gingiva. First, we'll detail about acute necrotizing ulcerative gingivitis or ANUG. ANUG has a lot of synonyms. So, whenever you hear any of these, you should come to a conclusion that it is ANUG. No one is going to ask you which all are the synonyms of ANUG, but be familiar. One is trench mouth. It was called trench mouth because it was found in the soldiers who used to live in the narrow trenches during the wartime and all. So they were out of stress, they were developing this ANUG. So one is trench mouth. Two is ulcerative gingivitis, stomatitis ulcerosa, acute ulceromembranous gingivitis because of the ulceration that is present, all these terms. 3 is pseudomembranous angina, okay, pseudomembranous condition with pain. 4 is Vincent's stomatitis, named after the author. Then plot Vincent's stomatitis, and then fusospirillary gingivitis based on the causative organisms, spirochetal stomatitis, then fetid stomatitis because of the fetid odor it presents, putrid stomatitis because of the putrefaction, and finally acute septic gingivitis because it's an acute infection of gingiva. Clear? Even though ANUG is having these many names, according to 2017 classification, necrotizing periodontal disease is the heading, which includes two diseases, necrotizing gingivitis and necrotizing periodontitis. So, there is no ANUG, there is no acute necrotizing ulcerative gingivitis, it is necrotizing gingivitis. Why this name has been changed? Because according to 2017 classification, WWP gave this explanation that there is no chronic necrotizing gingivitis. Necrotizing diseases are always acute. So, you don't have to specify the term acute. And this ulceration is a secondary feature to this necrosis. So, if you mention necrotizing gingivitis, that is enough, and it is no more known as ANUG, right? In 1890s, Plot and Vincent attributed the origin to fusiform bacilli and spirochetes. So these were the responsible bacteria, fusiform and spirochetes. Therefore, it is known as a fusospirochetal infection. And one important point is it occurs only in a susceptible host. I may also harbor bacilli as well as spirochetes in my oral cavity, but I may not get infected with the entity ANUG. So it occurs only in a susceptible host. Now we'll see the signs of the disease. These are the classical features of ANUG. You should look into the figure. There is a punched out crater-like depression at the crest of the interdental papilla. Can you see the crest of the papilla there? No. It is looking like a punched out crater, and it extends to the marginal gingiva. You cannot see the proper scalloped gingiva. It has been altered. The surface of the gingival crater will be covered by grey pseudomembranous slough. Because of the necrosis, there is pseudomembrane formation, and it will be covered by this pseudomembranous slough. And this crater is demarcated from the remainder. There, the interdental papilla's crest and the marginal gingiva is involved, and it is demarcated from the remaining unaffected tissue by a linear erythema. You can see a clear demarcation. But there are cases devoid of pseudomembrane also. When the pseudomembrane has been removed, it appears as red, shiny and hemorrhagic area. It will be red in color, it will be shiny as well as it bleeds. See, all these pictures are classical representations of ANUG. You can see that red and shiny appearance. You can see that crater-like depression. You can see the affection of the interdental papilla and the marginal gingiva and loss of the normal scallop. And there is gingival hemorrhage, and there is pronounced bleeding on the slightest stimulation. Now, what are the symptoms of ANUG? The patient feels fetid odor in his oral cavity. There is increase in salivation. The lesions are extremely sensitive to touch. On slightest stimulation, there is bleeding as well as there is pain for the patient. There is a constant gnawing pain, and it is intensified by intake of spicy and hot food and on chewing. There is a metallic foul taste in the mouth every time, and there is increased amount of, already we said there is increased salivation, but the consistency of the saliva also changes. It becomes pasty saliva. And one more important finding is it is found to be rare in edentulous mouth. One more condition where we saw that condition where it is rare or not present in edentulous mouth is DIGO or drug-induced gingival overgrowth. It is found only in dentulous area. Similarly, ANAG is also found to be common in dentulous oral cavity. So we saw the local signs and symptoms, what happens to the oral cavity which is affected by ANAG. Now let's see the systemic signs and symptoms. There is local lymphadenopathy and slight increase in temperature. Okay, the lymph nodes becomes enlarged. There is lymphadenopathy and there is increase in temperature, body temperature in the mild and moderate types. In severe cases, what happens to the patient? The patient experiences high fever, increased pulse rate, leukocytosis or increase in the number of the WBCs. There is no appetite for the patient and there is generalized lassitude or generalized fatigue for the patient. It is uncommon in children. This is an important question. This has been asked in MCQs. ANAG is not a condition that is common in children. But when it occurs, there is insomnia, there is sleeplessness for the kids, there is constipation and other GI disorders, headache and mental depressions can occur when it occurs in children. Another important point is it is transmissible but not contagious. What is the difference? Transmissible means you can transmit the fusospirochetal species in a consequent host. From my oral cavity, the fusiform bacilli and the spirochete can be transmitted to the oral cavity of another patient, but you can't spread the disease. It is not contagious. So it is transmissible, not contagious, because we already said this disease occurs only in a susceptible host. Now we saw what all are the external changes that is happening. Now let's go into the histopathology or the microscopic features. Microscopically, the lesion is a non-specific lesion. Acute necrotizing inflammation can be seen at the gingival margin of the stratified squamous epithelium. Obviously, our oral cavity is lined by stratified squamous epithelium and the underlying connective tissue. So just to expand the name, acute necrotizing ulcerative gingivitis, and you get all the histopathological features. Acute, and as we know, in any acute infection, neutrophils are the first cells to appear. So you can see phagocytosing neutrophils in the lesion. Then the next term is necrotizing. In necrotizing areas, what you can see sequestrum. So you can see sequestrum. Then when this pseudomembrane is removed, you can see ulceration. So ulcerated surface you can see. Then you can see the causative organism. Obviously, spirochetes as well as rods can be seen, and it will also be filled with inflammatory cells. So this is the histopathological feature. Now one author's name that you have to remember is Lisgarten. What did Lisgarten do? He studied the lesion, ANAG lesion, microscopically, and he found 4 zones. Which are the 4 zones? This question has also been asked. Which are the 4 zones in that same order? Zones 1, 2, 3, 4, from outside to inside, from the most superficial to the deep portion. You can see zone 1 is the bacterial zone. This bacterial zone consists of varied small bacteria. Small, medium and large, all sizes of spirochetes can be seen. In zone 2, it is neutrophil rich zones. Because of the presence of the bacteria which we found in the zone 1, leukocytes will come to fight with this bacteria. So leukocytes, especially the neutrophils, including the spirochetes and various types of bacteria, can be seen in between these leukocytes. Zone 3 is necrotic zone. As we already discussed, the bacteria appears, after that the neutrophils appears. Because of the bacterial neutrophil interaction, there is disintegration of the tissue cells, fibrillar material. We can see remnants of the collagen fibers, and you can see intermediate and large sized spirochetes, but not small sized spirochetes. You can see. In zone 4, which is the zone of spirochetal infiltration, you can see a well-preserved tissue, or you can see a relatively unaffected tissue. It is infiltrated with intermediate and large spirochetes without other organisms. So, did you observe something? In all the 4 zones, you can see spirochetes. In superficial or bacterial zone, you can see small, medium and large, all sizes of spirochetes. In zone 2 or neutrophil rich zones also, you could see spirochetes in between the neutrophils. In zone 3, you could see intermediate and large sized spirochetes. In zone 4 also, you can see intermediate and large sized spirochetes. Now that we learned ANAG, we will have a tendency, whichever necrotizing ulcerative lesions we see, we tend to diagnose it as ANAG. So we have to learn the difference between ANAG and similar conditions like diphtheria and syphilis. Let's see the difference. ANAG is caused by the host parasitic interaction. We already said only if the host is susceptible you are going to get the disease. Diphtheria is of specific etiology. Corine bacterium diphtheria is the bacteria which is going to cause diphtheria in our humans. Syphilis, secondary lesions of syphilis are called mucus patches. So mucus patches of syphilis resembles ANAG, and its etiology is again a specific bacteria, Treponema pallidum. ANAG area of affection is marginal gingiva. We already said the crest of the intestinal papilla and marginal gingiva will be affected. Diphtheria rarely affects marginal gingiva. So that is a differentiating feature. Again, syphilis is also rare in the marginal gingiva. We said there is pseudomembrane formation in ANAG, but the removal of the pseudomembrane is easy in ANAG. That also we already discussed. When the pseudomembrane is removed, you can see that as a erythematous and shiny area. In diphtheria, the pseudomembrane is very difficult to remove, but it is removable. In syphilis, it is not at all detachable. So that is the difference between the pseudomembrane. ANAG is a painful condition. It is very sensitive to touch. Diphtheria is a less painful situation. Just like syphilis also, pain is minimal. Then the most common area of affection for ANAG is, already we said, it is marginal gingiva. But for diphtheria, it is areas like throat, fauces, tonsils, or the posterior areas. Syphilis, any part of the mouth can be affected. Then ANAG immunity will not be conferred. It is not like once you get affected with ANAG and you are getting an immunity and you won't be getting the disease again. For diphtheria, immunity is conferred by attack. That is why there is a point in giving diphtheria vaccine, right? In DPT vaccine, we are giving diphtheria vaccine, which is using this logic. Immunity will be conferred by attack. In syphilis also, immunity is not conferred. In ANAG, the contagiosity is doubtful. We already said the disease is not contagious from one person to another, but diphtheria is very much contagious. Syphilis, only direct contact will communicate the disease. It is not like airborne or fomite-borne. Direct contact may communicate the disease. You have to call the patient for 3 visits. In the first visit, what you have to do is remove the pseudomembrane and the non-attached surface debris. After that, you should remove the superficial calculus, only the superficial calculus, using the ultrasonic scalers. Now your field is a little bit clean. After this, use hydrogen peroxide mouthwash every 2 hours. And how to use hydrogen peroxide mouthwash? 3% hydrogen peroxide and warm water in 1:1 dilution you have to take. Now there is another situation where we use hydrogen peroxide mouthwash, desquamative gingivitis. So what is the difference here? Here, more of hydrogen peroxide you are taking. You are taking 1 part of warm water and 2 parts of hydrogen peroxide. Also, you can give 0.12% chlorhexidine twice daily for the patient. So, hydrogen peroxide mouthwash is used very frequently. Every 2 hours you are giving that to the patient. Chlorhexidine is given twice daily, morning and night. Then there are patients who show systemic symptoms. For them, we have to advise antimicrobial therapy like penicillin or erythromycin, and metronidazole is also given to the patient. That much is done in the first visit. Then the second visit is 1 to 2 days later. The patient goes back and we'll tell the patient to come after 1 or 2 days. When the patient comes back, some of the symptoms would have subsided. By this time, we can finish the scaling. Scaling is performed. In the third visit, which is again 1 or 2 days later, by this time the patient will be symptom free. Then scaling and root planing should be repeated, and we can discontinue the hydrogen peroxide mouthwash. One more thing that you may have to do is contouring of the gingiva, because when we remove the pseudomembrane, it exposes a red hemorrhagic area with crater-like depressions and shiny surface. So we'll have to definitely recontour the gingiva as an adjunctive procedure. After finishing ANAC, the next acute gingival infection is primary herpetic gingivostomatitis. I strongly hope this is also a familiar area for you. What is a causative? It is a virus. It is not a bacteria. It is herpes simplex virus type 1. Age affected infants and children younger than 6 years. When we learnt ANAC, we said it is uncommon in children, but primary herpetic gingivostomatitis affects children younger than 6 years. It is rare before 6 months. So you can say the age of affection is between 6 months to 6 years. Why is it rare before 6 months? Because there is protection from the circulating antibodies from the mother. There is no sex predilection. Both the sex are equally affected. After the primary infection by herpes simplex virus 1, it resides in the trigeminal ganglion in a latent form or in a inactive form. Then this will be reactivated by various stimuli like any fever to the patient, any stress or exposure to sunlight. By this time there will be secondary manifestations and these diseases may occur like herpes labialis when it affects the lips, herpes genitalis when it affects the genitals, ocular herpes of the eyes, and herpes encephalitis when it affects the brain. Let's look into the oral signs. Diffuse erythematous, shiny involvement of the gingiva and mucosa will be seen. Look at the figure. It is diffuse, it is fully red in color, it is shiny, and it may affect the gingiva as well as the other parts of the mucosa. Multiple discrete superficial ulcers can be seen. It is not single ulcer, it is always multiple ulcers, and they are discrete ulcers. We can see that on the mobile mucosa as well as masticatory mucosa. It starts as a vesicle actually, and they rupture after 24 hours, and they form a painful ulcer with a red halo-like margin, and the center part will be depressed and it is yellow in color. Course of the disease is 7 to 10 days. That means it is going to heal in 1 week or maximum 10 days. But the diffuse enlargement and edema may persist for several days. Ulcers may heal, but the enlargement and edema will be there for some more days. There is no scarring after the ulcers heal. We know we may get figure-based questions. The first figure, we are all pretty sure it is a herpetic lesion, but the other lesions are also herpetic lesions. So, moving on to symptoms. One is soreness of the oral cavity, pain, and the ruptured vesicles are very sensitive to touch, thermal changes, and food. So, in general, pain and sensitivity, whereas ANAC had other typical features like metallic taste, fetid odor. So, that is how you identify. The extraoral signs and symptoms are almost similar. There is cervical lymphadenitis, then fever is there, and generalized malaise or fatigue is also present. If someone asks you what is the typical histopathological feature of herpes, you can say Zang cells are present. And what are Zang cells? When there is ballooning degeneration of the epithelial cells with acantholysis, nuclear clearing and nuclear enlargement, we call them Zang cells. Also, we can see multinucleated giant cells with intercellular edema, meaning to say the cells are giant cells and in between the cells you have edema. Then also we have intraepithelial vesicles. There is vesicle formation in the epithelium, and we can see one inclusion body. Which one is that? Cowdry type A inclusion bodies are seen in primary herpetic gingivostomatitis. So you have to remember, where do you see Cowdry type B inclusion bodies? That is found in poliomyelitis. So Cowdry type A in herpes and Cowdry type B in poliomyelitis. We know all the features of herpes. Now going on to the treatment. What treatment do we have to give? We have to first give symptomatic treatment. The patient is in pain, so we have to apply viscous lidocaine to the ulcers. Then we can use something called magic mouthwash, which is Benadryl cavopectate solution, and this can be used before and after the meals. Then one more thing we advise all our patients, we would have definitely encountered herpes patients during our clinics. We tell them you have to use copious fluid daily. So copious fluid intake is very important. Use of antiviral drugs because it is caused by a virus. Usually acyclovir 400 mg is given 4 times daily for 1 to 2 weeks, and this helps in shortening the duration and severity of the disease. Coming to the third acute gingival lesion, that is pericoronitis. What is pericoronitis? It is the inflammation of the soft tissues around the crown of a partially erupted tooth. So it is very simple. What are the clinical features? We would have all seen gingiva appearing red and swollen. Gingiva may be separative and it is tender, and it is often aggravated by trauma from the opposing tooth. Here also regional lymph nodes may be involved. Again, figure-based questions can be asked. In that, we often think pericoronitis, if you see a gingival flap overlying a partially erupted tooth, we often are hurrying to diagnose it as pericoronitis, but not every time that's the situation. Here on your left hand side it is pericoronitis because there is a flap covering that tooth and it is erythematous and swollen, but on the right hand side it is ANAC. That flap is also covering the partially erupted tooth, that is also erythematous, but you can see necrosis and pseudomembrane formation also in that case. So definitely it is not pericoronitis, it is ANAC. What are the symptoms? The symptoms are fever, malaise, that are the systemic symptoms. There is bad taste in the mouth of the patient, and there is severe pain which may radiate to ear, throat and floor of the mouth. Some patients complain, we have heard that, they tell, I have pain on this full side of my face, my ear is paining, my throat is paining. So this is because of the radiation of the pain, and some patients even find it difficult to close the jaws. How do we treat? Primarily what we do is we irrigate the pericoronal space mechanically to remove any debris that may have collected between that gingival flap and the tooth. And the commonly used irrigants are water can be used, normal saline can be used, chlorhexidine, and to relieve the pain, local anesthetic is also a good option for irrigation. After this, we may advise antibiotics for the patient, and depending upon whether the tooth will erupt, we can wait for the tooth to erupt, or if the tooth is not going to erupt, we can extract that tooth. That should be following radiographic evaluation. So that's all. That was a simple chapter. 3 acute gingival infections we learned. All of these we have encountered in our clinics, so it is not likely that we forget the findings. Anyway, we have to be thorough with these. You have to repeatedly revise. If you get any doubt, please feel free to contact me. Thank you.